going to focus a little bit more on our discussion of Medicare Advantage, I do want to give a shout out to the students. I was at the SNaHP Summit yesterday. Over 100 students here, right, coming to Chicago. It's amazing, it's inspiring. A sizable chunk of them have never been to a meeting before, which means we are basically getting them in to join this fight, and it's absolutely incredible. And two of those amazing students are Shruthi and Swathi Bhuma. So they're going to be giving a presentation to us on Medicare Advantage. They are fourth years here in Chicago at Chicago Medical School at Rosalind Franklin. They are political advocacy co-directors for SNaHP and chair and vice chair of the Illinois State Medical Society's Medical Students Section. They are a board member, well, one of them's a board member and the other's a board advisor for us on the board, and they are planning to pursue careers in emergency medicine. And so they're going to tell us a little bit more about this fight against Medicare Advantage. And so, guys, take it away.
Good morning, everyone. So my name is Shruthi, my name is Swathi, and today we will be discussing PNHP's Medicare Advantage campaign. Now, before we dive in, we'd like to take a moment to ground this conversation. We are all here today because we are united by the belief that we don't just accept the things we cannot change, we change the things we cannot accept. However, amidst the turbulence of this election, many of us feel caught between the hubris of hope and the paralysis of pessimism. PNHP has chosen to walk the line grounded by something we like to call idealistic sobriety. Idealistic in that we remain uncompromising in our vision of a single-payer healthcare system. Yet, sobriety in that we are deeply aware of the constellation of legislative, administrative, and political hurdles that stand in our way of making this vision a reality. This is PNHP's triple aim and is emblematic of that idealistic sobriety. Building on this principle, this presentation will focus on our Medicare Advantage campaign, aimed at fighting profiteering and improving Medicare. But more than anything, we see this campaign as a stepping stone, meeting people where they are, strengthening the existing Medicare program, and preparing the public to embrace a single-payer healthcare system. Okay, so now back to Medicare Advantage. Right now, in 2024, more than half of Medicare beneficiaries are enrolled in Medicare Advantage, or the corporate-run version of Medicare. And within the past 14 years in particular, we have seen Medicare Advantage morph into the Amazon of the senior health insurance world, where it has more than doubled its market share power from just 25% in 2010 to a whopping 54% in 2024. As Medicare Advantage enrollment grows, we're seeing yet another trend alongside it: consolidation. Today, just 4 companies, United Healthcare, Humana, Blue Cross Blue Shield, and CVS, control 73% of the Medicare Advantage market. Now, behind these corporations are 4 CEOs, the wizards behind the curtain, who wield significant power over pricing, access, and patient care. Like the Wizard of Oz, these CEOs operate out of sight, quietly pulling the strings that determine who gets care, who doesn't, and when, for millions of Americans. So when we talk about accountability in the private Medicare Advantage market, these are the people we need to picture. Let's zoom in on United Healthcare. They dominate the game when it comes to enrolling seniors in Medicare Advantage and have seen the fastest growth since 2010. But as it grows, smaller companies vanish. And it's no wonder United Health is extremely territorial. 46% of its revenue comes from the Medicare Advantage enrollees, even though they only make up 15% of the company's membership. Clearly, Medicare Advantage is the crown jewel of their business model, and they'll do anything to protect it. So you tell me, is this just the free market at play, or is it unchecked consolidation? Now that we've covered the trends of the past years, let's fast forward to last week, the day after the presidential election. Now, this reaction isn't exactly surprising. When a Republican takes office, corporate stocks tend to rise, thanks to the expectation of deregulation and market-friendly policies. But we know there's a little more to this market reaction. It's not just about the usual trends. It's also about Trump's past policies, congressional Republicans' ongoing push to strengthen the program, and then there's this. Introducing Project 2025, Mandate for Leadership. This 900-page manual, created by the Heritage Foundation and 140 former Trump staffers, outlines a plan to reorganize the federal government agency by agency to advance a conservative agenda covering nearly all aspects of American life, including healthcare. While the president-elect has distanced himself from Project 2025, his connection to its authors, and honestly, lack of other proposals, make it our best insight into what may come. So one of the recommendations include making Medicare Advantage the default enrollment option for Medicare-eligible beneficiaries. So in response to this publication, PNHP does what PNHP does best: crunch the numbers for the worst-case scenario of this statement. What would a world with 100% Medicare Advantage penetration look like? And more specifically, what kind of impact would this policy have on people? In addition to exposing a greater proportion of Americans to the myriad of harms inflicted by corporate-run Medicare plans, this would be the most salient consequences of this dystopian future. For patients, this would translate to extremely narrow networks for 4 out of 10 seniors, resulting in less provider choice, longer wait times, and poorer health outcomes. For clinicians, this would dramatically increase the amount of time spent on prior authorization, which not only diverts resources away from patient care, but also contributes to physician burnout through unnecessary paper pushing. Another question you might have is, what are the financial and economic ramifications of this policy proposal? Now, this graphic right here showcases the Medicare Hospital Insurance Trust Fund balance. The green line you see represents the projection of Medicare trustees throughout the next 10 years. The red line represents what would occur should 100% of eligible beneficiaries enroll in Medicare Advantage. There would be an immediate shift to deficit spending as Medicare Advantage plans cost taxpayers at least 6% or $27 billion more than traditional Medicare. The trust fund would become insolvent by 2030. And as you can imagine, this would render Medicare, the system we all pay into with the hope that it'll take care of us in our golden years, extinct as we know it. Now, Project 2025 also delineates other challenges and changes in the Medicare program. They include some repeat offenders, like the direct contracting entities, some rollbacks of governmental power, like stripping Medicare of its authority to negotiate drug prices, and the scariest of them all, intentionally vague policy statements, leaving the door open to the removal of consumer protections, the erosion of ethical guardrails, manipulation, exploitation, and unchecked corporate greed. So, given the possibility of this dystopian future, the question before us is this: what are we as an organization going to do about it? Now, while the strategy is still evolving in response to this shifting landscape, PNHP has identified a spectrum of engagement based on our past efforts and the expertise of our members. Here are 3 fronts where we believe we can have a substantive impact: legislative, narrative, and organizing. The first is a legislative approach. Based on PNHP's triple aim, our policy focus falls into 2 broad buckets. Number 1, secure more co-sponsors for Medicare for All legislation. And number 2, stopping enabling corporate attacks on Medicare. The specific policies we choose to pursue under this bucket will depend on the political opportunities that arise in this dynamic environment. Now, in order to curb corporate encroachment of Medicare, we must address the financing mechanism that disproportionately benefits Medicare Advantage corporations and undermines traditional Medicare. Let's break down how Medicare Advantage plans are paid. Now, there are three key terms I want you to remember: benchmark, bid, rebate. All right, let's go. Benchmark is a preset amount per person based on the average cost of a traditional Medicare beneficiary in that region. Now, that amount can be adjusted based on a patient's quote-unquote disease burden, meaning if a patient is sicker, the company gets an additional amount. Bid. Now, this is the amount a private insurance plan estimates it will cost them to provide an equivalent sense of care if they enroll in their health plan. Rebate. Rebate is the portion of savings a plan keeps if its bid is below the benchmark, somewhere between 50 and 75%. The benchmark can also be boosted even further based on star quality ratings, a bump that, quote unquote, doesn't exist in traditional Medicare where everyone receives the same standard of care. So why am I telling you all of this? From the payment model description, you can clearly see there are at least two obvious ways private insurance companies can game the system. Number one, upcoding, categorizing patients as having a higher disease burden to increase the benchmark payment. And number two, rebates. The lack of transparency and standardization make it difficult to determine how much funding actually goes to patient care versus profit, raising concerns that the benchmark may actually be a phantom one or benefit in name only. Now, as many of you know, last year, PNHP unveiled its overpayments report, quantifying the scope and scale of overpayments in the Medicare Advantage system. Now, estimates of overpayments, they vary depending on who you ask. PNHP puts overpayments at $140 billion, 106 of which could improve traditional Medicare. MedPAC, on the other hand, an independent congressional advisory board, estimates a more conservative $83 billion. Regardless of that estimate, there are large sums of money from the Medicare Trust Fund, money that we all pay into, directed into profits for a select group of private insurance companies. So I just mentioned two significant numbers, $83 billion and $106 billion, representing the range of corporate overpayments in the Medicare system. Now, what if that money could be redirected to improving the Medicare experience for all beneficiaries? What would that look like? Well, if PNHP had its way, we could finance a $1K maximum out-of-pocket, or MOOP, payment for every Medicare senior for $97 billion. With more modest expectations, we could finance a $3K or $5K MOOP for a fraction of that. FYI, a $5K max out-of-pocket maximum matches what most folks on Medicare Advantage get. And here's the real kicker. For roughly the same conservative amount that MedPAC estimates is wasted, we could cover a $5,000 max out-of-pocket cost, including all Part D prescription coverage, and offer all highly desirable supplemental benefits like hearing, vision, and dental. So how does this translate to legislative action? Well, there's a saying that it's not about showing up all the time. It's about showing up when it's time. And luckily for us, CMS actuaries have a set calendar for determining Medicare Advantage benchmarks and rate adjustments each year. Now, while there are many important dates on this calendar, I want you to focus on this yellow box. This is a golden window where we can mobilize our local cavalry and, in lockstep with our national allies, be prepared to lobby Congress. However, given the makeup of the Senate and the House this year, our definition of success might look a little different. Regardless, I want to take a moment to highlight some of our previous experiences and that advocacy truly makes a difference. Let's rewind to spring 2024. A coalescence of advocates came together to push for change. Led by Be a Hero, shout out to them, this campaign urged Congress and the Centers for Medicare and Medicaid Services to stick to their numbers rather than give to industry pressure. Through numerous meetings, letters, op-eds, these groups insisted that CMS uphold its proposed rates and prioritize patients over profits. And guess what? It worked. For the first time in a decade, CMS maintained its initial rate proposal, standing firm against industry pressure. The investment community, however, wasn't such a huge fan of this. Yes. Yes, let's hear it. Let's hear it for this, yeah. So let's just say that you know you're striking it big when your advocacy impacts the markets. Within 24 hours, here's how the stock market reacted. And of course it did. This was the first time in a decade that CMS actually stuck to the benchmarks and rate hikes calculated by their actuaries instead of just caving to industry lobbying. This shift in power was not only possible because Congress finally had the political cover from constituents, including PNHP folks, who are willing to speak out, including its allies. In short, advocacy works. So the second front that we would like to make change in is narrative change. In the age of information overload, trust has become more important than truth. And despite this post-truth era we're living in, according to a 2024 study in the frontiers of medicine, doctors remain the most trusted source for health advice. So let's leverage that trust in the following spaces. The first space is Congress. Technically, it's not untrue that the majority of ethnic and racial minorities and low-income individuals are enrolled in Medicare Advantage plans. However, the conclusion that AHIP draws from these statistics is false. A majority of these individuals are enrolled in these plans not because they're superior products, but because they are a fallback option due to limited financial protection in traditional Medicare as it currently exists. We at PNHP need to set the record straight and help Congress better understand the context and the why behind this data. Because ultimately, a system that harms people cannot be the solution to equity. And as physicians, we can dispel this corporate talking point with data and stories. The second space is the public sphere. Yes, PNHP has done some incredible work making the harms Medicare Advantage inflicts quantifiable and undeniable. But data means nothing without a face behind it. In order to help this report grow legs, we need you all to bring life to these statistics through your stories, as providers, as patients, as loved ones, to show the world the very human impact these harms are having on us. Because at the end of the day, facts don't unify us. Stories of everyday struggle do. The third space that is well within PNHP's wheelhouse is the research world. As we all know, research is the currency of medicine, and journal publications are the love language of research-grounded policy wonks. We need you all to submit your stories, coupled with PNHP's harms report data, to animate the real harms of Medicare Advantage in order to convince folks within our own sphere of influence, that is physicians, that Medicare Advantage encroachment really needs to stop. Last but not least is the organizing approach. How can we use the science of community organizing to advance our work in the fight against corporatization in Medicare Advantage? So earlier, Shruthi highlighted the growth in the Medicare Advantage enrollment. But did you know that a significant portion of that growth can be attributed to unions and employers enrolling their retirees in Medicare Advantage plans? Right now, 1 in 5 Medicare beneficiaries belong to a group plan offered by an employer or union. Now, let's ask ourselves, are employers and unions truly making informed choices between traditional Medicare with Medigap versus Medicare Advantage? Or are they leaning on simple heuristics, opting for Medicare Advantage due to lower upfront costs and bundled benefits? Well, consider the Cross-Union Retirees Organizing Committee in New York City, which discovered, shout out to them. Absolutely. They discovered that their union had moved 250,000 of their retirees to Medicare Advantage to save on the Medigap premium. Now, understanding the potential risks and harms of these plans, these union members went old school, with boots on the ground organizing, mobilizing fellow members, lobbying the city council, and filing lawsuits. And guess what? They won too. They proved that you don't have to live life by default. You can live life by design, actively shaping the reality you want. Now imagine if people all across the country embrace this ethos, united across generations and sectors to resist the profit-driven encroachment of private insurers in the Medicare system. We often use the phrase, speak truth to power, but what if we also gave power to truth? Today, we've previewed 3 potential approaches to do just that: legislative, narrative, and organizing. PNHP's strategy on this front is still evolving, and we invite all of you to be co-creators of this evolution through the afternoon workshops and beyond. Now, to close, I want to end with some lyrics from one of our favorite alternative rock bands from the early aughts, Switchfoot's Dare You to Move. There's tension between who you are and who you could be, how the world is and how it should be. While this election may have caused many to question the course of our democracy, our hope is by learning and leaning into this tension and engaging in these stepping stone battles, we activate latent potential, we broaden our support base, and prepare a public that is tired of the status quo and ready to embrace a new path forward: improved Medicare for all. Thank you.
That was amazing. Thank you.